Welcome back, everyone. I hope you all had a wonderful break. Wow, what a great two talks so far. Our next speaker is Dr. Cukor from all the way from New York, 3 hours time difference. Give us a talk. The topic is dear to my heart. It's identifying and treating depression in patients with renal failure treated with dialysis. Brief introduction for Dr. the Director of Behavioral Health at the Rogerson Institute in New York City, and he received his PhD in clinical health from Yeshiva University, and his research interests focus on depression, anxiety, sleep difficulties, pain, and caregiver burden in patients with end-stage kidney disease. Welcome, Dr. Cukor.
Thank you very much. Thanks for the introduction. Thank you for the invitation. So today, as we just heard, I will be talking about identifying and treating depression in patients with renal failure treated with dialysis. In terms of disclosures, I have some NIH research awards, but I don't think they're in conflict with anything I'm going to say today. Here are today's objectives, but in the interest of time, maybe we'll just dive right into the content. So the first thing I would like to talk about today is the epidemiology of depression, or perhaps another way of thinking about it, or why are the rates of depression so high? So just to begin, the prevalence of depression, it really depends on how it's measured and which subpopulation of people you're looking at. But in general, I think a pretty rough, good estimate is that if you use a structured clinical interview, which is the gold standard and the most conservative estimate of depression, we come out with about a quarter of patients who are on dialysis have major depression. And if you use a self-report measure and you use cutoff scores that are adjusted for the additional somatic burden for depression, if they need to be adjusted, we come up with estimates that about half of the people are reporting what we call elevated depressive affect. So this rate is obviously a quarter or 50% or wherever it might be in between. It is very, very high. It is higher than almost all other chronic illness communities. And it is curious, it's worth investigating as to why the rates of depression are quite so high. And this is, I guess, the beginning of my attempt at understanding why the rates of depression are quite so high in our patient population. So this is supposed to be a representation of, on the one hand, the 50-pound weight is life demands, and those are kind of all the things that we have to do in life, you and I and everyone else, including people who are on dialysis. And all of that demand requires a certain amount of psychological effort on our part. And for most people, if you talk to even healthy, well people, if you ask them, do you feel like you have extra reserves that you could handle more in life? Most people say, not really. Like, they're coping, they're doing okay, but they can't deal with a lot more than what they currently have on their plate. But now if we look at dialysis patients, so they have all of the regular life demands, but then they have some other things as well. They have illness effects, right? Like being sick. What does that feel like? What does that do for the way that they can operate every day, how much effort it takes? There's changes to their family dynamics as a result of being on dialysis. They have dietary changes. There's financial change and financial pressure that might occur. There's functional limitations. They can't do the same things that they used to do, or perhaps not in the same way. Many people have work status changes. They're on a host of medications. The average pill burden for dialysis patients is around 13 different prescriptions per day. That's a lot. They might have changes to their sexuality and to their sexual functioning. Their time demands, right? They spend a lot of time at the dialysis center. They have role changes, just different people in their lives that they have to relate to in ways that perhaps they didn't have to deal with in the past. And then there's this existential strain, I think, of, just knowing that you have a chronic illness, it's an end-stage illness, and, getting to know the people at the dialysis center and unfortunately watching some of the, eventualities that occur across the unit, that certainly takes its toll on all of our patients. And now, in particular, we have this, I've kind of made it this gray cloud on purpose. We have this gray cloud of COVID on top of all of that. And the reason why I've kind of depicted it that way is that it really highlights, I think COVID affects almost every single one of those boxes independently and then also directly the patient themselves. But all of these things have, everyone's lives have been turned upside down as a result of the pandemic and all of the social distancing that's required due to the pandemic. And that is perhaps even more true for our patients who have gone through a tremendous amount of change, often within the dialysis center and also just outside of the dialysis center. So there's just a lot that's going on. And with all that demand that is on that one side of the scale, so people have to mount a increased amount of effort to just keep that balanced. And what we call that is sometimes referred to as allostatic load, just the amount of effort that we have to put in to maintain equilibrium. And that effort, the more effort we need to put in, that actually takes its toll on the body over time. So even if we're coping well, as you can see, I've tried to show that the scale itself is beginning to strain, that it does take a tremendous amount of toll being under that amount of increased effort all the time. It's, if you want to think of an analogy, it's like, if you're redlining your car all the time, the engine just does not function quite as well. So this is a depiction that I have of what healthy coping might look like. And what we can see here is a person thinking about or getting ready to lift weights, and the demand is substantial. It's not that the weight is light. It looks like it's a heavy weight, but we have a sense that he might be able to lift it because the resources look sufficient. He looks like he's strong, and he looks like he's in the mindset, he's prepared to lift that weight. Now, if we go back to the example before of someone who's got all of this demand upon them, but they're unable to really mount the amount of psychological response to maintain that equilibrium, so then the scale tips and they are in disequilibrium. And my depiction of that looks like this. The weight obviously is larger, and the person does not seem like they have the physical or mental resources anymore to deal with that. So this is the image that I keep in mind when I'm talking with patients who just sound so depressed to me. I think this is what they feel like, and all the things that we're asking them to do, this is how equipped they feel to do them. So there's a relationship between depression and progressive chronic kidney disease. And the pathway on the left is the direct pathway, which is the one that I've just kind of spoken about, which is that as people become more depressed, they have more allostatic dysregulation. And many of those stress modulators, those hormones, are related to chronic kidney disease as well, and we don't have a pathway quite clearly described of how you go from one to another, but we know that there's many of the same neuromodulators are at play when people are depressed or when they have chronic kidney disease. But there's also an indirect pathway, which is that when people are feeling depressed, they don't feel like doing much of anything, let alone doing the things that they don't really ever feel like doing, such as following medical advice or engaging in healthful activities. So we see that people who are depressed are more likely to skip dialysis sessions. They're more likely to, less likely to go out on walks, less likely to do healthful activities, which we know obviously are healthy and prevent further progression of disease. So, there's a lot of research out there. Here's just a slide that summarizes it. That people who have higher rates of depression are more likely to have infection. They're more likely to be hospitalized. They have lower quality of life. There's an association between depressive symptoms and morbidity, meaning they have kind of more comorbid conditions. And there's also, interestingly, a direct relationship between depression and mortality. And there's a review study here that basically linked the rate of mortality of survival to be about 1.5 times. So people who are depressed are 50% more likely to die than patients who are not depressed. So depression, I think, is vital to people's mental health, but it is also vital to ensuring their physical health as well. So I hope that you are now with me, that depression is something which is important, that we need to really think about and be mindful of in our patients. So then the next question becomes, well, how do we identify patients? And the answer to that is some sort of screening tool and screening instrument. So this used to be the place when I would give this talk where I would kind of rail against the PHQ-2 and how I really didn't like its psychometric performance. I hope now that I think most of the dialysis community has moved away from using the PHQ-2. If you are still using it, let me just suffice to say, I don't think it's a very meaningful screening tool. These are tools that are out there. These are recommendations for the different tools. So the PHQ-9 is widely used in primary care. It is becoming increasingly used in dialysis populations and patients with CKD in general. There's also another inventory which has been validated in our population, which is the QUIDS, which is also a good instrument. And then there's some other instruments which are okay, but they have some setbacks, so they're not fully endorsed. And just to remind everyone what we're talking about from a DSM, or the Diagnostic and Statistical Manual, which is kind of like the Bible of psychiatric diagnoses. So major depression is defined as having 5 out of the 9 symptoms present in nearly every day in a 2-week period, with one of the first 2 symptoms having to be present. And the symptoms are depressed mood, as symptom number 1. Symptom number 2 is what we call anhedonia, or decreased pleasure or interest in doing things. And then there's weight change, change in sleep, change in your level of activity, fatigue, and then there's a cognitive component, feeling guilty, feeling worthless, difficulty concentrating, and then importantly, there is a question about suicidality, about increased thoughts of death or suicide, or if somebody has a suicide plan. So how these constructs translate to patients who are on dialysis is an interesting question, and it has kind of been debated back and forth, but it seems like they actually load pretty well despite all of the somatic burden, despite all of the extra physical challenges that dialysis patients have. The PHQ-9 in particular doesn't really require any sort of adjustment. So the PHQ-9 score is really used in the same way that it would be used in other medical samples. Now, very often people will get a 0 on one of these screening instruments. The patient indicates, none, no, pass, no thanks. And I think it's worthwhile spending just a moment being thoughtful about why do we get a 0 on depression assessments, in particular if there's a patient that that you wouldn't have guessed would be a 0, meaning totally absent of all depressive affect. So when a 0 comes in, it might be an indication that there's a true absence of anhedonia and low mood, that they don't really have any symptoms of depression. It could be a lack of understanding of the question's intent, or they might not like what the question implies about them. Are you feeling depressed? They would say, no, I'm not feeling depressed. I'm down every now and again, but I'm not depressed. Do you still enjoy the activities that you used to enjoy? So sometimes people will say, well, I don't do them anymore, so it's not really relevant to me. And they can very easily kind of misinterpret the types of questions that we ask them, and give an answer which is not quite what we're going after. It's also possible that people have a lack of desire to discuss their mental health issues. In particular, depending who you are and what role you have, some people think of this as very personal information, perhaps beyond the purview of the people that are asking. So they might not be interested in sharing that information. They might not be interested in kind of acknowledging it for themselves. There's a lot of stigma around mental health, in particular around depression. And then finally, there might be a lack of they might give you a 0 because there's a lack of faith that anything significant is going to happen if they tell you what the truth is. So, for example, if they think that the data is really being collected for the center's benefit or for your benefit in any way, why would you share very personal information if you don't think that anyone's going to respond to you? So, I think I like the KDQOL. I think it's a good instrument. But I think the way that it's often used is that, people kind of bare their soul, and if they just get, a standard sheet back which says, you've scored lower in this, we think you should do this, and it doesn't really seem like it's of meaning to the people that are responding. So that might, that I think weighs upon how seriously people take the answers to those questions and whether they want to be too transparent. So some of the things that I try to do when I speak to patients is, instead of using the PHQ screener tools or even the PHQ-9, I'll just say, how often do you do things just for the fun of it? In the last 2 weeks, have you gone to the movies, got together with friends, engaged in a hobby, or done anything where having a good time was the goal? Instead of making it a negative question, I make it a positive question and see what they say. Do you feel like your mood has been low, like it's hard to be optimistic or see the brighter side of things? How often do you feel this way? Again, trying to get an understanding of what level of anhedonia and depression and low mood they might really have. So again, the screening tools that we have are tools to get to the constructs that are underlying these tools, but sometimes it might be helpful to go beyond using those tools and just having a good old-fashioned conversation with people. So moving from screening to treatment, so I would like to talk about how we would treat depression and some models of care for moving forward. So I've put together, this is in my mind, the steps of the process that need to happen to go from finding out who has elevated depressive affect to actually treating them and then monitoring them. So first we have to identify who has low mood. Then there has to be a formal diagnostic interview. Someone's got to meet with them and decide that this is depression. It's not something else that looks like depression. It's not other things in addition. And then at that point, we have to provide what I've written here as stepped care, which is actually treat the depression. And then after that, we might want to treat all of the comorbid mental health conditions that might have presented along with that depression, such as anxiety, insomnia, often pain. There's a lot of issues that go along with being a dialysis patient and being a depressed dialysis patient. And then we need someone to do an outcome evaluation. We need to actually look and say, did we do anything meaningful here? Have we helped this person in a concrete way? And then if we have, great, let's move forward. And if we haven't, well, let's try something different. And that's why I call it stepped care, because if we haven't done anything that has helped, maybe we need to dig deeper into our toolbox and think about what else we can do for this patient. And I will certainly come back and talk about that in some length. And then finally, we need somebody, we need to have a system in place for relapse prevention or monitoring. We know from data from outside of the renal disease population that depression is a diagnosis that tends to remit and it tends to come back. So, there's a cyclical nature to it for a lot of people. So, we should certainly be on the lookout for patients that might have responded at one point, but might need some help again in the future. But I think where we are, the money question is like, okay, I think the government and dialysis centers are largely convinced that depression is something which is significant and that we need to treat it, which I think is, a giant step forward that we've taken, let's say, in the last, several years. But now the question becomes, okay, so what should we do and how do we go about doing it? And I'm going to spend some time kind of sharing my thoughts about those questions. So, it's said in other words, or what are the best treatments for depression in patients with end-stage renal disease, and how should we deliver the treatment to the patients? So let's focus on this first question first. And I'll start with, how do we treat depression in general in other populations, in all other populations? So the American College of Physicians, this is just one example of clinical practice guidelines. So the first-line therapies for major depression are one of two treatments. It's antidepressant drug therapy. In particular, it's selective serotonin reuptake inhibitors, SSRIs, or one of their kind of very similar types of drugs to that, or a particular type of psychotherapeutic intervention called cognitive behavioral therapy. And those are the first-line treatments for major depression in other in clinical practice guidelines. So it would stand to reason to me that those would be the approaches that we would want to start off with and then adapt and adopt for people with end-stage renal disease. So just to talk about SSRIs for a moment. So they have FDA approval for depression, anxiety, and pain, and they're often used to treat insomnia, agitation, irritable bowel, and headache. And I think if you look at that list, certainly that sounds like the type of drug that might be helpful for our patients. They have a lot of these issues. So you could certainly see why an SSRI might be a helpful choice for people who are depressed and on dialysis. And similarly, cognitive behavioral therapy has been demonstrated that it can be customized to treat depression, anxiety, insomnia, pain, sexual difficulty, adherence issues. So there's a lot of ground that can be covered. But I think unlike the SSRI, where you just can prescribe the drug and it hits all of those targets simultaneously, with psychotherapy, you have to really have a targeted approach. So a depression treatment might not be all that helpful for, let's say, sexual difficulty, or there might be some overlap between those constructs, but there might be some things that are areas that are not overlap. So they, depending on what the presenting issue is, the cognitive behavioral therapy or the psychotherapy might need to be targeted in slightly different ways. So there is a very small bit of literature that is out there kind of looking at SSRIs and looking at cognitive behavioral therapy. And just to summarize the state of the science, it's really, there are small scale studies that seem to indicate that there's positive effects for both, but they're largely safe, but they're really pretty small studies. And what I would like to do today is just kind of focus in on a recent trial that came out, which is called the ASCEND trial, which is a trial of sertraline and cognitive behavioral therapy in patients with end-stage renal disease. So this came out, this was published in 2019, and along with many other colleagues in many other places, I was a part of this study. And our goal was to compare the efficacy of cognitive behavioral therapy against sertraline for treating depression in patients receiving hemodialysis. So we were in 3 metropolitan areas across the country. We were in Seattle, New Mexico, and in Texas, and it represented 41 different facilities across those 3 geographic areas. And 60 patients were randomized to 150 milligrams daily of sertraline, which is commonly known as Zoloft, and or 10 patients, 60 patients were also randomized to 10 sessions of cognitive behavioral therapy, and that cognitive behavioral therapy was done chairside at the dialysis center by a licensed mental health professional, a master's level person, someone who worked for the study, not somebody who was part of the unit. And to make a long story short, both groups significantly improved on the QIDS-C after 12 weeks. So, after just 3 months, we see improvement in both of these groups. And I think that is a really, that to me is the main bottom line takeaway of the study, is that either of these treatments or both of these treatments were effective. To delve in a little bit deeper, so these are model statistics that we used. So 10 is considered the cutoff. So we had patients that were around 12 at randomization. And then you can see the filled in circles. That line is cognitive behavioral therapy, and the other one is sertraline. So sertraline had a slightly larger effect than the cognitive behavioral therapy, but both of them are significantly below the clinical cutoff. And if we look at the data a different way, if we look at change from baseline to outcome, so the cognitive behavioral group had a reduction of about 4.1 points, and the sertraline group had a reduction of 5 points. So it's really less than 1 point difference between the 2 groups. So in my mind, it wasn't statistically significant. It was barely significant, but certainly clinically not all that interesting. And then what is interesting, though, is that there were more than 3 times the rate of non-serious side effects in the sertraline group. And, I think that kind of goes along with a lot of the literature that we have seen, which is that, these drugs work, but there is a price to be paid, that a lot of people have additional side effects. And I should say they were relatively minor. No one stopped taking the drug because of the side effects. But again, this was a clinical trial, which was very carefully monitored, throughout the entire duration of the study. And I think it's just kind of interesting to comment about the adherence rates of the cognitive behavioral therapy. So 82% of people completed at least 7 out of the 10 sessions, which is a really high rate, partly because we decided to do it chairside to alleviate some of the barriers. But I think it just shows that there was some level of engagement by our patient population. And 72% of them were rated by the therapist as engaged in at least 7 of the sessions that they attended. So, 82% attended 7 out of 10, 72% were engaged in 7 out of 10. That's a good percentage, but, it's certainly not a cherry-picked percentage of people that were, very gung-ho about participating. And as you can see from our last statistic, about half the people did the homework half the time, which I think is, there was something that we asked the people to do after each session. I think probably in line with most people's kind of clinical sense of how this goes, it's about half the people half the time. So that was, again, not a very unusually motivated group of people that we worked with. We think they were actually just, quite representative of the normal dialysis population in that way. So, in thinking about what this ASCEND study means for clinical practice, I think the main take home is that, both of these treatment interventions were successful, and that for a long time, people are saying that, well, we don't really have evidence of what might work in our population, specific to our population. I think this study, sheds some light that we really do have data which shows that they're largely efficacious and safe. But there are still some, significant questions. So, for our study, for example, we screened nearly 3,000 patients to enroll at 120. So, I was saying that the rates are somewhere between a quarter and 50%. So, we had other inclusion criteria and exclusion criteria aside from depression, but you can see that it was a relatively select group of people that were invited to participate and then ultimately enrolled in the study. So, my thoughts about that is that, how would this randomized clinical trial compare to standard practice? So, it was a bit unusual because before randomization, people had to agree to be in the study, and they had to agree to either do therapy or medication. And we had to really have a sense that they were going to kind of follow through on either of those, if whatever they got randomized to. And in clinical practice and in real life, there are very few people that are kind of agnostic about which type of treatment they would like. There are some people that would like medication better and not talk about it, and there's some people that would like to talk and not take any more medication. So that's part of the reason why we had such a small sample. But also, I think because of that, and because we have felt the need to do it in such a short duration, because it was a clinical trial, and also we needed higher levels of initial depression to justify that people would start a medication, I think all of those things kind of favor medication, as opposed to if we had done this as a real world clinical trial and just allowed people to pick what they wanted to do and kind of treat them as long as we needed to treat them. I'm fairly confident that the cognitive behavioral therapy arm would begin to outperform given more time and more space. But I think a really important question that we did not answer is, there's 60% of the people were non-remitters. So that I showed you the average scores of, people certainly improved and everyone improved, but not everyone kind of crossed the reduction of the threshold of a 50% reduction. In fact, only 1/3 or so of people were really crossed that high threshold of what we consider depression reduction. So what about all the other people? What should we do with them? Let's say they've gone through one of these treatments and they've gotten some help, but they're not all the way helped. What should we do with those folks? So the study, the clinical trial, didn't shed any light on that at all, but I will kind of come back and talk about that in a moment. So I think, we talked about what are the best treatments for patients, and now I'd like to spend some time talking about how would we deliver this treatment to our patients. So, all across mental health and physical health facilities, people are thinking about how do we integrate, or what level of integration is the ideal amount between behavioral health care and physical health care. So to the left of this line, you'll see that there's multidisciplinary care, which really refers to each discipline doing their own thing kind of separately. And then a bit more integrated than that is what we call co-located care. So you might be able to offer different treatments at the same place, but there's really no meaningful collaboration between the people providing the care. And then there's something called interdisciplinary care, which is there's like a care team, and different people might report to that care team from different disciplines. And then at the highest level, there's something which is called integrated care, which is so interdisciplinary care is when they say, hey, how's this person's diet going? Let's go to the dietitian for a report on that. And integrated care is, what can we all be doing to help with this person's dietary issue? Maybe the dietitian can lead us in this discussion, but it's not really like their issue or that discipline's issue. It's really the issue of the entire team. So I've outlined some options for mental health treatment for the dialysis patient, and I think they kind of fit in different ways along that continuum, and we can kind of think about that as we go through it. And the main kind of general categories that we might have are an outside referral, which is obviously referring our patients to somebody outside of the dialysis center. We could have a consultant, which is somebody from the outside coming into our center, but they don't really work for the center, but they are independent contractors. Or we could have somebody who is in-house treatment, somebody who works for the same facility and they provide the care. So we'll kind of go through some of these in a bit more detail now. So if you refer out to a local psychotherapist, and I've attempted to, at least in my mind, kind of list the pros and the cons as I see it of these different approaches. So the pro of referring out, you can easily refer because you can have, you can refer all your patients on day one to as many therapists as you would like in the community or mental health clinics as you would like. It's kind of an easy way for the center to handle the problem. And another pro is that there's good protection of the patient's private health information because there's really not much integration of information between, the mental health people and the behavioral health people. And of course, if there's something which is urgent or extraordinarily important, they might share that, but the patient can begin to share their mental health issues without any concern that it might go back into their, if they don't want their physicians to know, they can keep it separate more easily. The cons are, it is very difficult for patients to attend. So it's easy for the institution to refer, but it's very difficult to attend. As a mental health practitioner, I will kind of say, from my perspective, I acknowledge that, all mental health clinics kind of, receive you with one arm and push you away with the other. It's difficult to find an appointment. There's often long waits. They often have a lot of rules. It can be challenging to really go and have that appointment. In addition, dialysis patients have, obviously their schedule is not their own, at least 3 days out of the week. So, if they're just given an appointment, it can become very difficult for them to schedule that and to find the energy. In my mind, this is not a great option in the sense that, what I always think of is, patients have a hard enough time going to the cardiologist, which is something that they certainly value and can appreciate the importance of. Getting their mental health care is just going to be lower on that list of, when they have just a limited amount of, emotional and other types of resources, it's going to be hard. And similarly, we don't really know who we're referring to, how good they are, what their level of experience is, and kind of doing some of my work and listening to people around the country hear about some of their experiences, dialysis patients going out to the community and the kind of bizarre and insensitive things that they've heard from therapists at first sessions. There's a lot of people who are just not that knowledgeable about what dialysis is or how to deal with people who have, a serious chronic illness. And then the converse of having good protection of PHI is that maybe it's too good and that there's not really integrated care. Either side doesn't really know what the other side is doing, so it doesn't really offer the opportunity for everyone to be on the same page about the same issues. There's an opportunity perhaps for like outside consultants or somebody to do telehealth with patients, at the unit or not at the unit. Again, they're easy to refer, good protection of PHI. It's easier on the patient's schedule. I think that's an advantage. There is a technology gap, and a lot of our patients in particular, it's difficult for them. They're not used to relating to people through telehealth, so it can become more difficult. I mean, they might be functional at it, some of them, in that they can get onto a telehealth call, but are they really comfortable in kind of sharing and talking in a normal fashion? My experience is that it's kind of a mixed bag. And again, we don't know the skill or the experience of the person on the other side, whether they're specially trained or not. Again, it's not integrated care. And there's a perception of risk to confidentiality. I guess there is some risk to confidentiality as your information is being ported through the internet, but I think for a lot of people that there's the perception of the risk of that confidentiality is a barrier for them to participate in certain telehealth activities. Maybe that will change with people's experiences through COVID, but largely it's been a difficult population to engage in telehealth for. So we can have an outside consultant come in. There's good team integration. They're probably an expert in mental health. They'd be an available resource in emergencies. But again, they're going to be hard to refer to. They have somewhat low capacity. If it's one person, how are they going to possibly cover, my dialysis centers run from 6 a.m. to 12 p.m. 4 days a week. 6 days a week. How are they going to do that? So are they going to actually make recommendations? Are they going to treat people? So having an outside consultant is, certainly something that some centers have tried, and I think there's some success with it, but I think there are limitations to how successful that model can be. So that brings us to some of the in-house treatment. So there's the unit social worker. So I think some of the pros of the unit social worker are there's great team integration. They're trusted by the team and by the patient. They're kind of a natural choice in some ways to do this kind of work. However, there are cons, and I think, some of this is not about, certainly not about the people that are employed in that way, but it's the way that that position is described, is that they don't really have the time in their schedules to meet with patients and to do a full psychotherapy intervention. So as I've listed here, they already have a full-time job. And I think that, part of this would, to change that would be amazing. And there are certain dialysis systems that are trying to change that to some degree, have more administrative support available so that the social worker is free to do more clinical work. I think as we would, as that would happen, they would need to be supported with education and supervision, not just around regulatory issues, but around psychotherapy issues. And then there also is a challenge to using the social worker in that the confidentiality is complex because they are so integrated into the functioning of the unit that there's certain information will be difficult for them to keep separate from the rest of the healthcare team. And also separately, but I think, the social worker's role is pretty diffuse. They do a lot of different things. So if a patient is acting up, if a patient has an insurance issue, it might be that it falls to the social worker to be the bearer of that bad news. So my recommendation, or kind of the final step here, is the full behavioral health service, which in my mind, includes the unit social worker with additional psychotherapists and psychopharmacologists available. And if they had a full range of behavioral health services available to our patients, we would have great team integration, trusted by the team and the patient, unique skills for the population. Confidentiality can be kept without gaps in care, and we could provide a wider breadth of services. And in my mind, the cons is, the cost or investment from the centers to be able to implement these types of interventions. But my argument back to that would be, if we can demonstrate that these are effective and that there's a need for them, then we can do we can get a lot closer to creating the need for that investment than if just saying, wouldn't it be nice? So just to kind of follow through on, the steps to depression evaluation. So, once we provide care, so then, our ability to provide what I'm calling here stepped care, which is the ability to provide a different modality of treatment once the first one doesn't work. That really only works if you have a variety of different specialists, mental health specialists working collaboratively. And again, similarly with the treatment of comorbidities and also with ongoing monitoring, you certainly need the involvement of the unit social worker in all of these models. So some challenges to the implementation of this is that, there's certainly stigma. Patients would need to be educated. I think physicians need to be educated. Healthcare systems need to be educated about how important depression is and how treatable it could possibly be. Another challenge is the availability of people to write these prescriptions and who the prescribers might be. There are different models and I think different pros and cons of having a psychiatrist, a primary care doctor, a nephrologist, a nurse practitioner from the unit. I think there's pros and cons of all of these. And then therapists I kind of went through, but there's a shortage of therapists, I think, in all of these capacities. And then, like I said, the reimbursement model. So just very briefly, I would like to just kind of go through a case example of how this might work. So the unit social worker could identify, hey, Mr. Johnson, I noticed you've been sleeping a lot more during dialysis. You seem kind of down. Could I do a screening test with you? Even though he scored a 0 on the PHQ-2 a month ago, the social worker sits with him, does the PHQ-9, and identifies the patient as a 13. They offer referral to an outpatient mental health treatment. The patient doesn't really, mental health services, the patient doesn't really want to go. But then when they offer someone who's in-house, who's an adjustment to dialysis specialist, they're more willing to do that. The patient shares that being on dialysis sometimes really gets to me. The therapist asks, what in particular is bothering you today? I can't provide for my family. What kind of man am I? In what ways are you not providing for your family? Anyway, sexually, financially, physically, I can't do anything anymore. All I do is come to dialysis. I can't eat what I want. I can't sleep when I want to. I'm always uncomfortable, and this is my forever. I'm barely a man. I'm completely useless. And then the therapist empathically replies, I can see how anybody who has thoughts that they're useless would end up feeling really depressed. So they offer medication consult. Patient denies it. They don't want it, too many medications, but they agree to chairside treatment due to the encouragement of the social worker, of the unit social worker, and they decide that they'll try it for 3 to 6 months, and if it doesn't really work, then they will kind of reevaluate where they are. So I'm just going to go through this quickly, being mindful of time. So the therapist begins to challenge the patient. Are these things really true? Perhaps you could think of different ways of defining yourself or defining your role with your wife. And the patient, yeah, this sounds simple on this one slide. This was, maybe 2 months of my life. And then the patient kind of comes around and says, I guess I could try something. And what I tried to get the patient to do was every day, his wife had to go back to work because he started dialysis, and he would just kind of sit on the couch. She would go out to work, she would come home, and he was still on the couch, and he was, hadn't eaten, hadn't taken care of himself, hadn't done anything. And she was very resentful when she returned from work and finding him in that state. So I said, as an experiment, why don't we try, let's see if you can make dinner one night, and let's see how she reacts to. So when she comes home, instead of finding you on the couch, she finds the table set. So one day she came home, found the table set. Her initial reaction was, what's going on? Did you get bad news? Are you dying? And he encouraged her, no, I'm fine. I'm just trying something new. And immediately that night was like a breakthrough night. She was able to share with him that she didn't feel like she was dealing with the new him she was not, that enamored with, that she really wanted to do more things to help get the old him back, where he was more than just kind of a needy person who was unable to help himself and really unmotivated to help himself, which was what she found to be most difficult. So chairside treatment ended after 3 months. The PHQ-9 was now down to a 7, which is, considered remission, but still had some issues, and the social worker picked up on it that 3 months later that they were still at a 7. He still had some fatigue, still had sexual impotence issues, and was still struggling a bit. So she encouraged him to kind of pursue all these different modalities of intervention, to take advantage of the broader healthcare team. And ultimately, the patient and their wife were more connected to one another, and they were extremely grateful to the unit for its holistic care. So just kind of as a conclusion here, I think depression treatment is certainly possible, but I think, ideally it should be integrated, built into the dialysis system. It needs to be iterative, that we have to be built for understanding that people are not all going to respond to the same types of modalities, and that we're going to have to come back and do it multiple times and multimodal. We have to have different tricks up our sleeve. And again, patient-oriented, we need to be able to meet patients where they are and offer the type of treatments that they're interested in at those particular moments. Here are some supplementary resources that I've included. And here's just a bit about who I am. We have, I think, just a few moments for questions, but if we don't get to all of them, I welcome you to all, feel free to reach out to me via email. I'm happy to kind of continue the conversation.
Great. Thank you so much. What a wonderful talk. Anybody has any questions, please put in the chat box. I saw a lot of comments. I think Mary asked the questions, how much time CBT section have for the patient during the, I tried to find her question.
Yeah, it's a question that I get often. So in the research study, we did like 45-minute sessions 10 times. And now in my clinical practice at the dialysis center, we've got it down to eight half-an-hour sessions. So it's once a week for half an hour, 8 times.
Any more questions? If not, if I may ask a question, I sometimes back my previous question to Dr. Schreiber about we focus too much on small solute clearance for our patient instead of forgetting the big picture of the person. I really like the question you asked. Are you able to enjoy life? What kind of things you do have fun? My question to my patient is always, are you able to do the things you used to do? I think those are the things we look at holistically, the whole person. Sometimes I feel like we are probably adding more burden to our patient by too much focus on their phosphorus level, their KT over V, all those. If a patient is happy, I'm not sure whether we should still focus on that. One example is during one of a QAPI of my dialysis clinic, my nurse told me, so-and-so did not pass the adequacy because she forgot to collect the urine. The reason she forgot to collect the urine is because, quote, she was partying all night, unquote. I was like, if a patient can party all night, she's happy, she's doing well. Do I really care about what the KT over V is? But the clinic have to respond to the government metrics about how well you do. I think as a renal community, we really need to come up with a better metrics to measure how well the dialysis is.
Yeah, and I think some of the new models that are being proposed now certainly have more patient-centered outcomes as built into those reimbursement metrics, and I think that's a really I totally agree with you, and I think that's a really nice step that the government is beginning to take, because I think that's exactly right. Getting people to the point where they're feeling comfortable with their health or feeling happy about where they are should really be our goal. And those metrics are really just ways for us to measure how far away from that perhaps we are. But let's not focus exclusively on just getting people within those target
I was
ranges.
reminded our time is up. Thank you so much, and really appreciate a great talk.
You're very welcome. Thank you, everyone.